Don Saposnek, who has done so much for APFM, PhD, is a clinical child psychologist and family therapist in practice since 1971, a child custody mediator and national and international trainer and consultant since 1977, and a founding board member of APFM. He serves on the editorial boards of several international journals of conflict resolution, is editor-in-chief of APFM's publications, and has published extensively in the professional literature on families, children, divorce, and mediation. He is the author of Mediating Child Custody Disputes, a Strategic Approach, and co-author of Splitting America, How Politicians, Super PACs, and the News Media Mirror High Conflict Divorce. He taught on the psychology faculty at the University of California, Santa Cruz for 41 years and is adjunct professor at Pepperdine University School of Law, Strauss Institute for Dispute Resolution. And without further ado, I'm happy to present to you Don Saposnek.
Thank you. Thank you, Cliff. I'm always wondering what, if it weren't further ado, what kind of ado would it be? Splitting America now more than ever. I encourage you to take a look at that book that Bill, Eddy, and I put together. It's more relevant than ever if you just turn on the TV for a second. This topic, special needs children in mediation cases, is one that I came up with probably about 10, 15 years ago when I was asked by, at that time, Andy Shepard, the editor of Family Conciliation Court, to do a special issue on special needs children because I had published an article, I forgot where that was, on this topic, and it was apparently the first article published that people hadn't been looking at this issue. But for years before that, I had been seeing lots of cases in my mediation practice where there were special needs kids of various sorts, and they typically weren't being addressed in other mediations that I had seen other people do. And I thought that I knew quite a bit about childhood psychopathology and a lot of disabilities that children had because I've always been interested in children. As a child psychologist, one would think. And I got to seeing more and more of them in my mediation caseload and thought, we need to educate people about this because they really need special parenting plans. And the ordinary parenting plans didn't seem to work for them because their needs were being left out. So I took all my knowledge of basically my course in childhood psychopathology that I've been teaching at the university for 41 years, plus 15 other courses that were related to children, and decided to put together an article and then a special issue in Family Court Review with a number of other authors on the same topic. And I started doing workshops around the country on this topic and found a lot of interest, especially from lawyers who had not a clue of what these various differences were and what the implications were for their mediation cases. So I thought I would put together what I consider the three major categories of special needs children, detail out what those needs were, how those kids functioned, and then how they played out in divorce, and then obviously what they needed in parenting plans to service their needs properly and not just treat them like just another ordinary mediation case where their needs are seriously unmet. So this workshop is intended to sort of lay out the bones of that kind of thinking. And as a preface to it, one of the articles that I've found just sort of a classic is this article by Tseng et al. These are research psychologists at the University of Hawaii back in the 1970s. They came up with this typology of families that have 6 categories, and the last one is what's relevant. So I want to just sort of show you what they're after. What they did was they took a bunch of families in which there was a symptomatic child, and they took instead of putting the child in therapy and exploring them there, they took the child out of the family system. Basically, they plunked the child out of their home, put them on a hospital unit, special unit for 2 weeks, And then they studied the family's interactions before the kid left, after the kid left. They'd study the kid in the unit to see what they do, and then they'd study the reunion responses when the kid was placed back into the family. And out of this research, they came up with 6 family types. Some of them are familiar to most therapists and maybe even the public at large, and some aren't. I just want to briefly go through these to show you the difference and then show you the category of the typology that's of concern to us today. So the first was considered a parent-reactive family, and these were families in which there was one parent maybe with an alcohol problem, an abuse problem, psychosis, bipolar, some kind of problem that the child was reacting to. And from a family systems point of view, we look at what is the child's influence that creates this particular symptomology. So these kids were developing symptoms, all kinds of symptoms, acting out and getting depressed and anxiety and depression, and the usual host of characters, but they didn't know the cause of it. And so what they found in these families were that this parent was having a problem, the child was reacting to that particular parent's problem. And they found that they take the child out of the house, put him in the hospital unit, and what happens is the kid calms down and looks perfectly normal. All the symptoms would go away. And then when the child would be reunited with the family, the symptomology would come up again. The family, when the child was out of the family, another child would start becoming symptomatic even within 2 weeks because the parent was still there doing their nasty behaviors, and a different child would be reacting to them. So they call this parent-reactive family type. And what they do in that situation is obviously not worry about the child's symptom. They treat that parent with the problem. Second category was marital reactive. This is the most common one that people recognize. The old family systems theory that we grew up on was that when you see a child with problem, bring the family in, and as soon as possible, get the child out of the room and keep the marriage there. This is when there were marriages, way back when. And then you treat the marriage and the child's symptoms go away. Same thing if you take the child out of the home and put them in the unit in the hospital. Sometimes they'll get the staff fighting with each other, and if they don't, the child's symptoms would go away. And at home, the parents would continue fighting and triangulate another child. So you get the picture of how that works. So the marital reactive families, when the child was specifically reacting to the tension in the family. We obviously see a lot of this in divorce. But that's not the focus of this workshop, because all the other workshops are talking about everything we know about marital reactive families and the tension between parents as the best single predictor of long-term outcome of the child over 30 or 40 years. The more the conflict with the parents, the greater the pathology over a lifetime, the less the conflict, the healthier the child is. With the only qualifier research that Joan Kelly pointed out, I think it was Cummings and Davis, showed that it wasn't actually the amount of conflict, it was whether there was a resolution. So if the parents have conflict, it's actually good if they resolve the conflict in front of the child. Anyhow, the marital reactive was the next category. And the third category was called unresolved triangular family. And this was a family in which the child was reacting, or one of the parents was reacting to the child's behaviors. So for example, first day of school, a parent who had a lot of school phobia or school refusal as a child would suddenly freak out that the child was going to leave them, and they would start overcompensating and asking the child 1,000 questions, asking them if they feel good, and pretty soon the kid would pick up on the message of, oh, there's something supposed to be wrong with me to help my mom. So they develop symptoms, and they would act that out for the mom, but it was unresolved triangulating the child of a developmental issue of the parent. Excuse me, I don't want to go too much more into this. Special theme families is when there's things like a closet alcoholic that nobody's allowed to talk about, or the death of a family, the death of a member of the family that nobody grieved, at a family where 2 kids who were teenagers one of the brothers, as teenagers, died, and then they weren't allowed to ever speak of that. And the second child started getting depressed. He used to be a straight A student, and he started falling apart. And it turns out, after several family therapy sessions, the kid finally says, "How come you never mentioned my brother Robert?" And everybody went silent. And I asked. It turns out that was the first I had found out that brother had died. So this is a special theme. This kid got depressed, seriously dropped out of school. Within a week after that session where we unveiled it, the kid was back to getting straight A's back in school. So that's, and also sexual molest in a family, incest that's not being talked about is a special theme. The panpathological is when you have every single member of the family with pathology. These are often criminal dad, prostitute mom, drug abusing kids, and these are the cases that go into child clinics, and all the interns cut their teeth on it. They just pass this family on to the next set of interns who have their fun, because you can't really do anything wrong with them, because every time you solve one problem, they pop up with 3 more the next session. So the kid who's in the panpathological family, they go into the unit and they recreate the panpathology. They stir up everybody in the staff and residents to have problems. It's kind of an interesting. Now, this last category, which is the subject of the rest of this workshop, is what they call the child reactive family. This is a child who's showing the same symptoms as these guys, but there's nothing in the family unit that's causing it, except the family is reacting to the child. This is a situation where the child has a problem. It could be a physical problem. It could have cerebral palsy. They could have severe asthma. They could have diabetes. They could have developmental delays. They're not very smart in school, getting bad grades. They could have a difficult temperament. I'm going to go into the categories of this, but this is essentially the family is reactive to this child. ADHD, a child is running around, hyperactive, really intense, and driving everybody in the family nuts, and the family goes into chaos and dysfunction and turn on each other because of this child. You take the child out of the family, put this child in the hospital, and they do that to the whole staff, and the staff either reacts to it or doesn't. But back at home, the parents feel tremendously guilty because they feel at peace for the first time. And they talk about feeling really guilty, feeling good without this child. And, you know, parents aren't supposed to not like their child, but they don't like this child because he or she is causing a lot of chaos and they don't know it. This child reactive family is the same kind of kid who comes into divorce, except we don't know that unless we look into it, which is hopefully what you'll be able to do after I finish this presentation. If you can unsurface, a lot of times a child reactive family that gets divorced, when I'm doing mediation with them, I discover that, which is pretty obvious to me because I look for that, and then recreate what would have happened if this child were different. And the parents, after their resistance out of guilt, finally acknowledge, oh my God, this child caused the breakup of our marriage. And I've said for years that this adage that we always have, oh, the child is not responsible for the breakup, you didn't do anything, this is an adult decision, blah, blah, blah. I'm not sure that that's accurate because I've seen lots and lots and lots of families in which the child was the cause of the breakup as a child reactive family. And once they get that, sometimes they've actually reconciled, recognizing it wasn't a bad marriage, it was actually a good marriage before this child had these problems and created this chaos in the family. The siblings who came to turn on each other and hate each other recognize, oh, it wasn't you, it was our brother or sister. And what I call these kids is they're innocent but functional contributors to chaos. I think we have to stress that I'm not holding them responsible. They're just born the way they are. And unfortunately, their behavior, as a result of being born the way they are, functions to create a lot of chaos in families and often breakups of their parents' marriage. So as mediators, we're in the position of what do we do about these kids in mediation, because we can't redo the family. That's just an unfortunate consequence of certain kids coming into the world. So when I thought about all the kids that I've seen and all the families and all the complications, they came up with these three categories of special needs children. One is acute life-threatening medical conditions, and I'll go through each of these in detail. Second is chronic developmental disorders, and the third is psychological and behavioral disorders. And I think I pretty much captured all the special needs that I can think of, at least the major ones that present themselves to mediators and certainly to therapists. Therapists may see a wider range, but mediators certainly see these three categories. So let's look at each one. So acute life-threatening medical conditions, which are the most common types I'm going to show you because there's an unlimited number of medical conditions. Asthma, one of the most common ones, 7 to 13% of all kids have asthma. I think those stats have actually increased. These data are a few years old, up to 44% in urban African-American neighborhoods. And you know what the central reason for getting asthma in urban neighborhoods is cockroaches. Apparently, cockroach dander, or their legs, or some part of the cockroach that disintegrates when they die, turns into dust. And dust is a specific, cockroach dust is a specific allergen for a lot of kids and adults who wind up getting asthma as a result. There's also the usual suspects of dust, mold, pet, dander, tobacco smoke, upper respiratory viral infections, and stress. I think the most common are dust and mold. These are probably in the order of the triggers for these kids. Dust and mold. So dust is everywhere. Mold is that nasty stuff that you don't ever see. It's in the walls, in certain areas where there's a lot of moisture. And pet dander, the allergies to cats and dogs. That's except for, I think, what is that? There's a couple dogs that don't have hair, that don't have fur, they have hair, and there's no dander in there. So I think Obama had one of those dogs because they had allergies. So you can get a dog without dander, but mostly it's the flaking of the skin from the fur that flakes and distributes with people walking across the room, and then asthma gets triggered off. Tobacco smoke was an interesting, unique one because, first of all, the fact that smoking went down dramatically when the federal government got involved, which was just an amazing phenomenon to me because it's one of the most highly addictive known substances, and yet they cut it down dramatically. Family courts, I remember back in the day, we had debates about whether a parent smoking tobacco in a house was reason to deny custody and or visitation in the home. There were laws passed as a result, and eventually it got into, I'm not sure if it was legislated or just local jurisdictional rules, but most family courts now, excuse me, do consider the presence of tobacco in a car and or a home as a reason to cut back or deny a parent's contact with their children, which was a second mind blower for me, that family courts move like molasses in terms of changes, and this was such a major one. But yet society got rid of tobacco mostly, at least cut it way back, and then family courts actually made changes as a result of that awareness. Upper respiratory viral infections, these are kids who regularly get asthma attacks after they get a cold. There's a lot of people that have that. And the asthma, it basically triggers off the asthmatic response and continues on even way past weeks and months and even years past the particular cold infection. And then this little bugaboo called stress, which is a challenging one in a lot of conditions, because sort of like when you can't explain why somebody does something, a lot of religions say, well, God caused them to do that, or the devil made them do it. Well, in psychology, we say stress made them do it. And in medical research even, they're saying when they can't figure out a causal relationship, they attribute it to stress. And then there's lots of physiological and medical research showing that stress, in fact, does create all kinds of problems, from heart conditions to lung diseases to cancers to everything. It is related as a correlate, not necessarily a cause, although some people, particularly in Santa Cruz, Marin County, believe it's the cause of everything, and they'll directly address it. Okay, so kids come in with their parents complaining, one parent complaining the kid has asthma, the other's often downplaying it, and you have to figure out what's the reality of the asthma in this co-parenting family and address it. Well, let me just go through them and then we'll talk about remedies. Food allergies, another, in terms of life-threatening, an asthma attack is life-threatening. If you don't have albuterol and you don't take care of this child's collapsing lung capacity, the child can die, literally. They can seize up and suffocate to death. So it's really, really important that these kids have albuterol with them, which is the short-term, quick-acting sprayer that will open the lungs. It opens the bronchial tubes within minutes, and then the child can breathe normally again. But if it's a chronic asthma condition, meaning it wasn't just a simple exposure to dust, but that the child has chronic asthma, allergic to all sorts of things, even stress and unknown factors, you have to then take corticosteroids on a daily basis, along with always having your albuterol spray with you. So a child who has asthma cannot go without their albuterol spray canister on their person at all times, because they could go running with their friends and exercise will create an asthma attack, or they could eat something that creates a food allergic response, which I'll get to shortly, that also can create an asthma attack. They can go to some friend's house and there's a cat in the back room that nobody even mentioned, and the child's allergic to cat hair or fur and suddenly has an asthma attack. And if they don't have their sprayer, they can't breathe. And what happens is the person starts panicking that they can't breathe, which makes them hyperventilate more. And the more you hyperventilate in an asthma attack, the more your lungs seize up. These kids, in the more severe condition, they wind up in the ER a lot with an asthma attack, and they get shot up with adrenaline and various other activators to open their lungs again, and sometimes long-term sprayers until they reach a particular test home and get away from your allergens. Well, if you have two houses and the parents aren't talking with each other, and one parent refuses to even admit that the child has asthma because the other parent told them so, and you know that one. I'm not going to do anything you told me to do because you're such a controlling person, and that's why I divorced you. So they take it out on passive aggressive, I'm not going to worry about asthma. The kid just doesn't have it, just denial of it. And then the kid sees up, there's no spray, and they go to the ER and the kid dies because they didn't make it in time. So I call these life-threatening because they are life-threatening. It's not just a little bit of asthma. So parents have to really be on board, knowing about asthma, knowing the particular triggers of that child, and having the supplies on hand to take care of it. You can't wait on asthma. Food allergies, the next most common type that I see, that I think most mediators see if they ask about. And I use that the operative term, you have to ask about these things with every family. Just like we've gotten into trauma-informed interviewing, you have to do allergy-informed interviewing, because they won't tell you unless you ask, necessarily, unless they're fighting over it already, in which case that's an issue of their parenting dispute, and that's why you need to have special parenting plans developed for these kids. Okay, food allergies, most common, it affects about 6% of school-age children, and again, I hear that's probably gone up to 8 or 9% at this point. That's a significant number of millions of children. 90% are triggered by milk, eggs, peanuts, wheat, soy, and nuts. So if the child is triggered by milk and soy, that means soy milk and regular milk are out, and eggs are out, And peanuts, it means you can't fly Southwest because your child can die on the plane if you have a severe peanut allergy. Tree nuts usually, peanuts and tree nuts are usually yolked. I shouldn't say yolk because I just said eggs, but joined together. And Southwest, although they try to serve pretzels, sometimes they do serve peanuts. And I've heard stories of kids who are on a Southwest flight who almost died on the flight. So you got to be really careful about things like that. When the kids go to school, young kids will share sandwiches. So a kid who doesn't get peanuts at home will get a little rebellious and go to school and take half of a kid's peanut butter sandwich in exchange for their salami sandwich. And then they seize up in school, and the school isn't prepared because the other parent refused to tell the school that the child has peanut allergy. Then you have a child who's getting an ambulance and being taken to the ER, and all the social stigma and embarrassment, et cetera, plus the kid could die. So food allergies are very much like peanut allergy, let me see here. There's two types of reactions to food allergies. I was going to say that they're like asthmas in terms of a high prevalence of it, and the triggers are in the everyday environment. So, going over to a friend's house, you could get the asthma attack. Going over to a friend's house and the kid gives you a chocolate chip cookie, and the chocolate chip cookie has a peanut in it. Or mom was chopping up peanuts before she made the chocolate chip cookies. So the kid eats a peanut without knowing it, and the friend didn't know it. Nobody's doing it intentionally, but suddenly the kid can't breathe. And he's over at a friend's house, and mom and dad are gone because they left him at the friend's house. And now the friend's parents don't know what to do or what's going on. And you can imagine the scenarios that cascade from there. So food allergies come in two types: the allergic skin reaction, which is atopic dermatitis or eczema. It can be an allergic reaction. And the other is an anaphylaxis, a total body shutdown. Anaphylaxis, if you've never experienced one or seen one, it's pretty scary to watch somebody. They grab their throat, they feel like they're going to die, their toe tightens up, they can't breathe, and if you don't do anything, they die. They suffocate to death right in front of you. Anaphylaxis might also have some atopic dermatitis with it, but it goes into an anaphylactic response if you don't treat that. So typically the allergic skin reaction is not fatal. It's just really annoying because you're scratching. The more you scratch, the more the abrasions get bloody and pussy, and you wind up scratching and spreading it around, and pretty soon your whole body potentially is covered with dermatitis or eczema rashes. So what happens then, this becomes kind of a chronic condition where the child, especially younger children who have eczema as an allergic response to food allergies, once they get an attack, they continue scratching, and that becomes then a iatrogenic kind of thing. The more you scratch trying to relieve it, the more you get rashes. And eventually you have to have lotions and medications and everything, Benadryl. And those type of medications will stop the reaction, stop the itching. The anaphylaxis is, some kids just go directly into an anaphylaxis with a food allergy, just eating a peanut. Let me see, so let me just tell you a couple stories of what I've experienced. So I had a family come in, and they described, actually, I think it's the next kid that I'm going to show you. They described this kid had such severe peanut allergy that they went on a Southwest airline, and this flight attendant, the little girl was sitting in the middle seat, but she was a baby. She was 6 months old. The mom was holding the baby, and dad was sitting on the window seat, and the stranger sitting on the other seat. So the flight attendant reached over to give dad his peanuts and accidentally brushed the lip of the baby with the packaging. of the peanuts. And the baby started going into an anaphylactic reaction, and nobody knew why, because the child didn't eat anything. Turns out this child had a severe food allergy to peanuts before the mother knew it or the father knew it. And they couldn't figure out that the airline was, they were questioned about it, and they said, no, there weren't any open peanuts. It was just a bag. Well, the peanut bag had been in a big bag, and one of the bags had opened up, and peanut dust had gotten around, got on the bag, touched the baby's lip, and it doesn't have to be swallowed. Just contact with the body from a severely allergic child can cause an anaphylactic response. Luckily, there was a doctor on board who shot this kid up with adrenaline. They landed in the nearest airport. This baby then survived, and she grew up into a little girl who turned out to be one of my clients. And another instance is she once went to Safeway supermarket, and the parents bought popsicles, innocent popsicles. The girl ate it, wound up in the ER. And it turned out that popsicles, they checked how they were made, and when they checked the manufacturing, they found that popsicle was made on a conveyor belt that had milk products, and this child was severely allergic to milk. But there was no milk in the popsicle, in the packaging. It said, just popsicle stuff, iced water, with some other flavoring. So the place that the popsicles were made had a conveyor belt that used milk materials. Nobody ever knew about any of this, but they tracked it down that way. So you can get hidden foods, food allergies in packaging that are completely innocent, and you'd never guess where that stuff came from. So parents who have food allergic kids regularly check the packaging and everything, and unless it proactively states not made in a facility that has tree nuts, they have to proactively state that on the label by law now. If it doesn't say that, they could use it indirectly and not have to announce it because they weren't actually making tree nut products, but they had some other allergen on their machinery. So parents of these kids look through packaging, and they have to go to special stores, sometimes 2 or 3 stores, to find a given product that doesn't have what their child's allergic to, or a product that might have it innocently placed in there. They often do research, the careful ones. They go back to the manufacturer and question them, and then the manufacturers now know they're prone to lawsuits if they aren't honest in advertising what's going on. If asked, since the FDA doesn't require complete disclosure on a whole lot of stuff. Okay, so food allergies. So we have parents in a room where they're arguing about the kid has peanut allergies, and the other parent says, no, they don't. I've never had any problem with it. Did you ever give them peanuts? No, I kind of stay away from them, but I don't worry about that. You have to check the packaging. Oh, you're overprotective, blah, blah, blah. You heard all of that. So if you have a kid who potentially could die, you want to write that into the parenting plan as a court order, and you want to inform judges and lawyers about these things, especially in the severe types. Okay, let me move on here. So this is a girl, Rachel, 7.5-year-old girl with severe food allergies. She came in to me as co-parent. It was a co-parenting situation, but they brought their girl in because they wanted me to meet her. They were actually almost perfect pals, cooperative colleagues, high-level cooperative parents, but they were concerned about the child. And they wanted to know what they needed to do as co-parents. So she had severe anxieties about vomiting. She carries an EpiPen. Well, I didn't mention the EpiPen, including albuterol. For both food allergies and asthmas, you have to carry an EpiPen. And you probably have all heard in the news recently that the manufacturers of the EpiPen, which used to cost about $30, they send it up to $500 for the EpiPen, which is absurd and life-threatening for so many kids who couldn't afford that. Anyhow, there were lawsuits, and they cut it down to $300, and now I think it's down to like $90 with special coupons you can get to get your EpiPen down. Anyhow, it's insane in our greed for money and not caring about what the consequences are for the kids. Albuterol also went up dramatically one day because the manufacturer wanted to make more money. Anyhow, carrying an EpiPen for allergic kids is essential. It's a pen that's about that big, comes in a little package, and you take the cap off and you stab it into your thigh through the clothing. You stab it in, and it gives you about 20 minutes to get to the ER. It's basically an adrenaline shot, and it opens up your vessels, your lungs, so that you can get to the ER so they can do a more infusion of whatever they need to do to stop this allergic reaction of asthma or food allergies. So Rachel always carries her EpiPen. It's a little awkward for her in school because she sometimes doesn't have pockets, but her mom sews pockets on every clothes she has, so she always has her EpiPen with her. If she goes without her EpiPen, she now gets really scared because she knows what can happen if she doesn't have it. So kids will trigger off obsessive compulsive tendencies of just worrying about their EpiPen and general anxiety because their life is threatened if they don't have their albuterol or EpiPen. She fears accidentally touching peanut butter, which a lot of kids have, and any contact on her skin of peanut butter will send her to anaphylaxis. She gets eczema all over her body. She tries to hide it with her clothes and tries not to scratch it, but it itches a lot, especially for months after she touches any kind of peanut butter or any tree nut. She can't go to restaurants because think about restaurants. They have short order cooks in the back who aren't thinking about the stuff unless they're asked. So these parents go and talk to the chef directly when they walk into a restaurant, and some places can't guarantee you that they didn't cook their steaks on the same griddle that they had cooked scrambled eggs from this morning. Even if they scrubbed it off, you can't guarantee that every morsel is scrubbed off, and one touch of an egg to the steak to the plate where the kid eats the first bite of steak and suddenly goes into anaphylaxis. It sounds like I'm exaggerating, but I've heard countless stories that these things actually happen. So this kid is afraid to go to restaurants. She mostly can't because she has so many allergies. So the parents have their life compromised, and when they get divorced, guess what? One of the parents wants to go to a restaurant, and they're not going to turn over the child to the other parent because they're pissed off with them for not returning the kid on time. So they go to the restaurant with the kid, and the kid, innocently, a young child, maybe 3 or 4, runs around, touches somebody else's table that had peanuts on it or an egg on it or milk. And suddenly they shut down, and now you have a custody fight if the parent don't agree. This is Rachel's self-portrait. I said, draw a picture of yourself. She was 7.5. From a psychological view, just looking at this child, it's a well-formed, well-organized, suggesting good cognitive organizational ability. She's got good proportions. She's got a good aesthetic sense. She's got details of fingers, of lips, of cheeks, of eyes. The more details in a picture, the more highly correlated it is with overall intelligence. She's got shoes and feet and legs. For a 7.5-year-old, that's a pretty sophisticated drawing. And look at the coloring too. She's expressive. She's a very vital, really delightful little girl. Just she could talk about anything. She's very open, sharing her feelings, etc. So then I asked her, what are the foods you can't eat? She said, can I draw them? I said, sure. So she draws milk and peanuts and ice cream, because it has milk product, eggs, chickens that lay eggs, soy, and cheese. So she knew all the foods she had to stay away from. Obsessively, she knew them and was terrified of getting near any one of them. When she'd go in a grocery store, she would avoid the aisles that had those displayed because they bothered her just to look at these foods. I said, what is it like when you have an attack? She said, can I draw? I said, yeah. So she draws this bright red dress that's like on fire, and she's flaming with radiating flame. She says, this is what it feels like. She said her eczema acts up and I just feel like I'm on fire, and she said, I need a fireman to come and douse me with water and put me out. My face lights up and my hair gets red and my whole body is just itching. and she's afraid of vomiting. So I did a little intervention. I said, let's make a picture here of a kid vomiting. So we code drew this, but then she drew this part and just started scribbling, showing that's vomit. She said, I'm the barf queen of Seattle. That was really cute. I think she had lived in Seattle when she was younger, but then they moved to Santa Cruz. So she was the barf queen of Seattle. Okay. So another type of acute life-threatening medical conditions, diabetes, type 1 diabetes. So diabetes, for those of you who don't know, come in two types. Type 1 is insulin dependent, meaning you can't live without taking insulin every day. And type 2 is insulin resistant, but not dependent. And with those, you can control by losing weight. Usually the fat cells in the body somehow create resistance of sugar getting into the cells, which is what insulin does. Insulin acts as a catalyst to sugar and the breakdown of all foods into sugar to getting into your cells to giving you the energy that you need into your bloodstream. So in type 1 diabetes, the pancreatic islet cells, which are the cells in the portion of the pancreas, die over a period of time. There's a honeymoon period, which can last from months up to a couple of years, where you're still producing insulin, but less and less. The islet cells are slowly dying. And some kids, just their islet cells, once they get the first onset of diabetes, their islet cells all die, and they no longer are able to produce insulin endogenously. So they have to take exogenous insulin in the form of an injection. You can't take it in pill form because the stomach will digest it and defeat the purpose of it getting into the bloodstream. So it has to be injected. So they learn to take needles. They quickly learn to give themselves injections. Even kids as 4 and 5 years old give their own injections. Certainly 6 and 7-year-olds are capable of learning how to give their own injections. And many of you, I know, are probably terrified of needles. Well, imagine being a 6-year-old child who's suddenly told they have to give themselves shots, 2, 3 a day for the rest of their lives. Well, there's some new devices, insulin pump now, that you just inject this one insert into your belly or your thigh or wherever, and you tape on a package that has insulin. There's actually some new devices. I don't want to go too much into them, but essentially you don't have to inject yourself with a needle each day, but you will be infused with insulin with an insulin pump. It's like a little cell phone device you wear on your hip or in a pocket. And the calculations are requiring a PhD in mathematical analytics to figure out how to calculate these things. But for kids, the parents do it. Even in parents not well educated have a hard time keeping track of these things. It's a great technology, but it's not simplified enough yet to do it. They do have a system now. In addition to insulin, you also have to do finger sticks in your finger to check your blood sugar levels separately from the insulin injection. So there's a lot of needles involved in diabetes. Rigorous daily multiple testings of blood. You have to test your blood sugars up to 6 to 8 times a day by sticking your finger, putting it on a little strip, putting it in a little meter. The meter again looks like a cell phone meter. You stick it in there and it reads out what your blood sugar is at that moment in time. There are devices now that are trying to hook up the meter with the insulin pump to have it like a closed loop system, very much like the pancreas and the blood system. The pancreas and the blood system works in our body naturally, but when neither of those work anymore, you have to figure out how to get the data of how much insulin you need or don't need. The requirements require daily injections, rigorous 6 to 8 times of blood testing a day of your blood sugar, and then calculating how much insulin you need or how much food you need. So diabetes is it's a tricky balance between how much food you're taking in and how much insulin you need. And that balance is constantly fluctuating. So the parents have to regulate how much food the kid gets, when they get it, because when you're giving insulin injection, it has a curve of effectiveness, and you have to match the food at the peak of the curve. If you put the food in too early, your blood sugar goes up and you don't have enough insulin to cover it. If you let the insulin go in your body and you don't have enough food to cover it, you go into insulin coma, diabetic shock, and you die. If you put too much insulin and then you cover too much food, your blood sugar goes up, and then the insulin curve of your body gets out of whack, and it'll be 2 or 3 days to re-regulate it. So the timing of the food, the type of food you eat, and the amount of insulin that you're giving, and when you're giving the insulin, morning, afternoon, night, whatever, all has to be coordinated in a very sophisticated algorithm that doctors first figure out, parents learn to figure out, and little kids have to obey. So what if you have a kid with an oppositional defiant disorder and you have diabetes and the kid doesn't want to give insulin, doesn't like needles and won't listen to you, and sneaks off and eats foods that he's not supposed to eat that are going to raise the blood sugar level, and the blood sugar levels are going into the 800-900 range, in which case they're soon going to go into a coma and wind up in the hospital. And then you have one parent who's not cooperating with the other parent. So you can see the high risks involved here, especially with younger children, because this is such a complex matter of monitoring and restricting food intake by type of food and frequency and timing. Physical activities and exercise is the other tripod leg of this thing. If the child exercises too much, their blood sugar drops. And if you don't give food, the insulin is too much for the amount of blood sugar, and they can go into shock by just taking a run or exercising. And then level of stress, this X factor. When you've covered everything known medically, and you're still getting high blood sugar levels or low blood sugar levels, both of which are dangerous to the child, and somebody's not carefully monitoring it, including the stress level of the child, they attribute it to stress. Because if you're doing everything right, getting all the proper exercise at the right time, the right amounts, the right food, you still can go into a diabetic coma and or insulin shock, or your blood sugars are into the dangerous level because of stress. And some kids don't show stress. They're kind of quiet, introverted kids. Internally, they may be showing a lot of anxiety or stress, but they don't express it, they don't tell you. And in divorce, we know that kids tend to shut down in talking about it because you have to keep secrets in a divorce between the parents. And if the parents don't know about it and they aren't attuned to their child, the child can die. And when the parents won't cooperate, you just put their casket out there. Really, really critical, especially with diabetes. We're seeing a significant increase of 6 to 7% per year of diabetic kids. Who knows why? Maybe genetics, maybe the environment. I got a little blip on the screen. Cliff, were there any questions about this so far?
There were really comments, not for everybody, rather than questions.
Okay, thanks. Okay, so the second category that I came up with is chronic developmental disorders. These are autism, and about 5-6 years ago, we got rid of the term autism and Asperger's, and we replaced it with Autism Spectrum Disorder. For purposes of this lecture, I want to look at the old terms because they're informative. And I was partly sad that they compressed Asperger's and autism into Autism Spectrum Disorder, partly because it messes up the research. It also makes it really difficult to understand by parents and professionals of what the heck it is. So I like to go back to the original designations when we first learned about this thing. I first learned about autism in 1964 when I was working with Ivar Lovaas, who founded the Applied Behavioral Analysis program of intervention. And in my work with him, we worked with these first 4 autistic kids at the UCLA Neuropsychiatric Institute. And they were bizarre children. They were kids who would just sit and rock and twiddle their fingers and flap their hands, and they had no language, and they make ee wee 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 wee, and that's all they did. Avoid eye contact, avoid people like the plague. And they were classical autistic children. And they were absolutely fascinating to me, and it's always been a special interest of mine throughout my entire career. I've always worked with kids with autism and watched the whole trajectory conceptually of what's happened with this condition. It used to be considered caused by a refrigerator mom, Bettelheim's whole notion, because what they found was that, well, what he found was that when he'd see families of autistic children in the office, the mothers seemed to be detached from the kid. As the kid was sitting, spinning plates and rocking in the corner, the moms, because dads never showed up during those days, they were just father figures floating around the periphery making money or something. So moms would go into psychoanalysis, and Bettelheim would see them in Chicago at the, I think it was called the Neurogenic Institute. But Bettelheim would see the moms kind of detached and looking kind of cold. So he described the first sample as cold, calculating refrigerator mothers. And what he didn't know is that if you grow up at that time, when nobody knew anything about autism, you have an autistic child as a child reactive disorder coming into a family that's functioning fine, and this kid won't relate to you, won't look at you, avoids you, pushes away when you try to touch him, sits and rocks all day long, won't learn anything. The mom doesn't feel like much of a mom. And in those days, it was firstborns that were autistic because we didn't know really much more about that. And firstborns were these wealthier parents in New York City were taking their kids into psychoanalysts, where the first samples were discovered by Leo Kanner in 1943. These are analysts in private practice seeing autistic children and looking at mothers and assuming mothers caused everything, because psychoanalytic theory was the predominant theory of child development. And what they didn't know is the backwards causality. If you have a child who won't relate to you, who avoids you, and you're trying to be a mom, you're going to feel rejected and pull away. And so the mother's cold reactions were actually a reaction to the child reactive disorder rather than the cause of it. Over the years, there were hypotheses of biological theories, and eventually we learned the genetics of it, like an 85% heritability for autism in families. I'll talk a little bit more about that. So it clearly is a genetic disorder. It's neuro-developmental, meaning it goes on a lifetime from birth, and lifelong disabilities. Increased prevalence from when I first started, it was 3 in 10,000 live births in the 1960s. And now it's 1 in 59 live births. And as Autism Spectrum Disorder in the new designation as of 2014, there's 1 in 37 boys have autism and 1 in 151 girls. It's still about 4 to 1 boys to girls. It used to be 8 to 1 and then moved down to 4 to 1. Increasing number of boys are coming into the mix. There's genetic theories about why boys over girls, because boys are genetically weaker as a species than girls. At every stage, almost every disorder except anorexia has 3 or 4 or 5 to 1 boys to girls, every disorder. So there's some inherent genetic weakness. The most recent findings is that there's a significant increase of autism and schizophrenia in children born of fathers over age 45. And what they're finding is that the genetics of male sperm break down over time. And the old thing, we used to think that women who are older women, like in their 40s giving birth, are going to have Down syndrome more often because women, their genes break down. What we didn't know is that it's more likely the fathers, specifically in creating autism and schizophrenia. And my theory about this is that we've got this high divorce rate has resulted in men marrying younger women after divorce in their 40s, and they want to have new babies. So the new woman is a younger woman, she has babies, and the man who's 45 to 50 to 55 having a baby is increasing the incidence of autism because their genes are broken down and nobody's telling them about that. Anyhow, side thought. So autism results in an impairment of multiple areas of functioning, including intelligence, attention, memory, language, sensory perceptual, and always with serious withdrawal and social deficits. difficulty reading social cues, avoidance of humans, because we used to think it was a psychological thing, that because mom was so cold to them, they didn't attach to the mom. But the actual understanding currently is they're avoiding people and avoiding eye contact because it's sensory overloading. Eye contact is a very powerful sensory overload. Descartes talked about it as the windows to the soul. There's something about eye contact that's phylogenetically, you see animals, dogs will avoid facing each other and will look down, avoid eye contact to avoid an aggressive confrontation. Salesmen in car sales shops will look you straight in the eyes as a way of controlling you. They'll stare at you and say, you really want to buy this car, don't you? One anthropologist once told me that if you were caught in a jungle and a gorilla appeared, the safest thing to do is look autistic. Just avoid eye contact, look around like you don't notice the gorilla, and you'll be safe. But if you look in the gorilla's eyes, they will attack. Just as you look at the eyes of an aggressive dog, they'll attack. But if you look down, they'll walk away. So there's something serious about eye contact that autistic genes produce to avoid overstimulation, confrontation, and things that they aren't able to screen out. Okay, Asperger's syndrome was considered a condition similar to autism, but they don't have the language and cognitive deficits. So with autism in early development, you see a lot of cognitive deficits. They aren't developing normally. They're delayed in learning certain things, and their language is unusual. They have pronominal reversal in the early years, like mixing up you and I. Mommy, you want a cookie. Mommy, you want a cookie, instead of I want a cookie. And they have weird language things like memorizing little limericks from commercials and things and repeating them over and over. They have echolalia, they have echolalia, they have echolalia. If you ask them a question, how are you, Johnny? They don't give an answer. They say, how are you, Johnny? How are you, Johnny? How are you, Johnny? How are you? They play with the question that is just a sound pattern, but not a meaningful sentence. So these things don't happen in Asperger's, only in autism. In Asperger's, you get the opposite. You get cognitive development that's extremely high. They're often very, very bright, unusually bright, and their language development is hyperlinguistic. They can learn 2-3 languages at age 2 and 3. So autism comes with delays of all of those cognitive and language, and Asperger's comes with the opposite end of excessively developed. And yet when they both merge at about 3 or 4, they both look indistinguishable. So that's why it's always been a question of whether Asperger's is high-end autism or whether it's a different beast entirely. We resolved that problem by calling it all Autism Spectrum Disorder, getting rid of both the terms autism and Asperger's. Moderate to severe impairments in reading social cues. This is the main problem with Asperger's or high-end autism or high-end less severe autism spectrum disorder. So autism spectrum disorder now ranges from those kids, those classical autistic kids spinning and twiddling their fingers and rocking, all the way up to people like Bill Gates and these guys who are clueless socially, but they're brilliant in their professions. They can be very successful people, but the difficulty in reading social cues, they just don't get it. They don't understand relationships. So they get made fun of. They don't understand sarcasm. They have a hard time understanding other people's humor, although they can have their own unique, idiosyncratic sense of humor that's just wonderful to listen to. They have archaic thoughts. They think in terms of, they love living in the 1800s and the costumes and the way people talk in weird ways. Difficulty making friendships. About 70% of adolescents with autism have depression, or Asperger's, high-end autism, have depression, because of the fact that when they get into high school, they see all the other guys having girlfriends, and they want a girlfriend really badly. They're not really asocial. That was a misunderstanding of autism. They want to be social, they just don't know how to do it. They don't know how you get a girlfriend. So it becomes a problem. Let me move on here. Learning disabilities, 2 to 10% depending on the research sample. It's really hard to do the research on this because they're often mislabeled or not labeled or thought to be just stupid kids or thought to be kids who are just goofing around, because they often do goof around when they aren't understanding something, even though they're bright. So specific learning disabilities are a wide range of cognitive, language, receptive, and or expressive disorders that make learning difficult. They could be dyslexic, they could have difficulty understanding math, difficulty learning language, difficulty saying language, retrieving words, or difficulty understanding other people's expressions. So it's a huge range of stuff that gets deciphered out by a good neuropsychological exam. And neuropsychological testing sometimes is really, really helpful in getting parents to cooperate and understand the deficits of the child. I need to go back for a second. I realized I didn't tell you the consequence of autism spectrum disorder to co-parenting. So if you have a child with autism, sometimes one parent denies it, sometimes both parents deny it. I've had kids 8 and 9 years old who are sitting in my waiting room spinning plates and twiddling and doodling and making weird noises but no language. And the parents say, oh, they're perfectly normal. That's not what we're here for. We're here because we're disagreeing on stuff. So what do you mean? Look at your kids. This is normal? They say, yeah, you know, they've always been this way. We just love them so much. And they completely will be blindsided by something obvious to anybody else. Usually it's not that dramatic. The kid has signs of autism and one or both parents don't understand it. But the consequences for social development, for intellectual development, for the rest of their life is based on whether these parents get on board with helping these kids. In co-parenting situations, especially if one parent's denying it, you need a good neuropsychological assessment. You need an autism rating of this child. There's specialists that use the ADOS, which is sort of the major tool now, acknowledge the ADOS-2, where it's a rating scale to measure all the symptoms or behaviors of the child to see if they fall on the autism spectrum disorder. And once they get that disorder, they can get special services in school. Once they get that diagnosis, if it's not diagnosed, the school won't offer services in many cases. And if they have the diagnosis, then they're eligible for all sorts of services. The other thing about autism is if it's a young child, the sooner that they get identified and diagnosed, like by age 2, ideally, by age 3 for sure, if you wait any longer, you're losing there's a window of opportunity to basically get in there and rewire the brain using applied behavioral analysis or social learning models. But it has to be a really intensive intervention early on. And they literally are operating on a ticking time bomb if they're arguing about the child. So this is when I just tell all my stories of horrible outcomes if you two don't get together and get this kid properly diagnosed. I'll see the kid sometimes, give my own assessment, which I can identify pretty quickly because I've seen so many hundreds and hundreds of kids with autism. And if you don't know that, just get a psychologist, just make one referral to a child psychologist, have them see him for an hour, and you can get that diagnosis. But you got to get these parents on board to get these kids in interventions quickly and intensively. It can't be once a week talk therapy. It doesn't touch it. This is a rewiring of the brain. The more early you get it, the more plastic the brain is, and it can change. If you wait till later, the brain is locked into unhealthy patterns that are going to be really hard to break later. So consequences of autism, or even one parent saying, I think my kid has some kind of ASD, pay attention to that because it's got lifelong consequences. Learning disabilities, if you don't correct those early, also you wind up with bad learning habits, and the child gets, either if they don't know about it, they'll start clowning around to distract from how embarrassed they are that they can't learn this one thing even though they know they're smart, or just learning bad habits of work habits, and they eventually drop out of school because they can't learn and they feel embarrassed and all their friends are moving ahead and they're not. These are easily corrected. You can get remediation. There's some real expert educational therapists that can remediate learning disabilities. So don't dismiss these. These are very important to the trajectory of a child's development. And just because the parents are not agreeing, get them together to agree and get court orders to support that if needed. Okay, then psychological and behavioral disorders. Difficult temperaments, which is 10% of the population of normal children, and slow to warm up temperament, which is slow to warm up to changes. Temperament is, I do whole day workshops on temperament, but anybody who's interested, I'll be glad to share bibliographies and information about that. But these two temperaments together, these are two of three. There's an easy child temperament, a difficult child temperament, and a slow to warm up temperament. When they cluster all the characteristics that have been unbundled into, I have 17 dimensions. The original New York longitudinal study by Thomas Chesson Burge came up with 9 dimensions. And then over the last 30, 40 years, I've added from the literature of well-researched other dimensions to come up with 17 that I use in virtually everything I do. Excuse me. The cluster of characteristics that are significant of these two combined are erratic biological rhythms, meaning they aren't hungry at the same time as the family, they aren't sleeping at the same time as the family, they might be all over the place. They might go to bed at midnight one night and 5 in the afternoon the next night. They may eat 3 peanut butter sandwiches at 3 in the afternoon, then 5 o'clock comes and they sit down at dinner and they say they're not hungry. Each parent then accuses the other of causing it, who knows what. But this is a child reactive pattern that these are genetic characteristics, they're hardwired in, they last a lifetime. And as opposed to regularity of bodily rhythms, the regular kids fit into every pattern pretty easily, and they eat at dinner time and they go to sleep at the parents' assigned bedtime. But when you have a kid who's biologically not following the pattern's parent, the parents turn on each other and cause it. You're keeping that kid up at late at night. No, I tried to put him to sleep and he wouldn't go to sleep. Well, it's because you did blah, 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 blah. And you've heard all of those things. So before they get into accusing each other, a quick assessment of several temperament characteristics that are relevant in co-parenting is really important. Negative withdrawal responses to new stimuli. So a positive response to new things is sort of adaptable child, and a negative is a child is more negative mood as temperament as opposed to positive mood in general. That's not caused by anything except hardwiring. A withdrawal to new stimuli is a slow to warm up to changes, which is really challenging for parents who are busy, and they drag their feet. And when the parents start accusing each other, I'm trying to get the kid out the door in the morning, they won't go, and they say, Dad doesn't make me go so fast. And then the parents start arguing over parent styles instead of the child's temperament. As an aside, you have to create a goodness of fit with these temperament styles. They don't change, but they will get worse if you put stress on the child because hard. Adaptable kids who just don't shift gears easily from one activity to another. Intense moods, intensive response. Some kids talk really loud and everything they touch is really aggressive. And some kids are very gentle and very quiet and they sort of glide across the room. So again, all of these are characteristics that are hardwired that the parents in divorce will start accusing each other of causing or maintaining when it's not that at all. And a little bit of education about temperament can go a long way to covering some core arguments of parents. Okay, ADHD. It's actually a prevalence of 3 to 5% in the population. It's not 25 to 50% of all boys. We've gone crazy since the early 60s with ADHD. It used to be called hyperkinetic disorder, where the focus on the hyperactivity, and then it got called minimal brain dysfunction, and then minimal brain disorder, and it had about 15 different names, and hyperactivity disorder. And the most recent iteration of it is called ADHD, attention deficit hyperactivity disorder. They tried for a while to get rid of the hyperactivity and call it ADD, just because it's easier to say ADD than ADHD. And once it got Oprahfied, got on Oprah and she had somebody calling ADD, they called it ADD, and people think that's a thing and it's separate from ADHD, but it isn't, because the researchers kept finding every time they did clinical trials, they couldn't get agreement among diagnosticians unless this H was there, unless there was hyperactivity. Attention deficit disorder doesn't exist on its own in the research sample. But in the DSM, they cobbled it together and called it ADHD with just inattentive type, with just hyperactivity, or combined type. And you pick one of those. But they snuck in the ADD as inattentive type without hyperactivity, even though in clinical trials you can't distinguish it as a condition just based on inattentive, because it overlaps with almost every other pathology. When a kid is in school and they aren't paying attention, it doesn't mean ADD. It could mean anything: depression, anxiety, family problems, etc. So when you go into research, you have to have the hyperactivity. So ADHD kids, and I'll just label it like everybody else does because that's what you're going to hear, require special educational behavioral techniques, not special education, which is the old kids who used to ride the small yellow school bus, but special educational, which means within a normal classroom, a completely mainstream classroom, you can be using educational techniques that are directed toward that specific child. Behavioral techniques for increasing child's focus and attention, and sometimes medications. I'll talk about that in a minute. So ADHD is a real popular common thing. Everybody knows it. Every single person on the street has heard of ADHD, although sometimes they call it AHDD or AD. They don't know what to call it because it's an awkward term. Parents with a child who's been labeled this need to pay attention to it, but not in the usual way. Because for a proper diagnosis of ADHD, remember that ADHD symptoms are very similar to other symptoms. The classic symptoms of ADHD are, I thought I had them here. Oh, here. High activity level, short attention span, distractibility, and impulsivity, meaning quick to warm up. On my temperament profile, in the first 9 characteristics, dimensions that are listed, there's all 5 of these characteristics as a normal developmental profile, degrees from one end to the other. So they're all dimensional, they're not categorical, but once you cluster it as a syndrome called ADHD, you have to categorically look at these things, yes or no. It's not degrees of it. And then the DSM will diagnose it based on that. But in fact, ADHD symptoms are very similar to other childhood disorders, all of these. Anxiety, depression, conflict disorders, adjustment disorders, divorce reactions, learning problems, poverty, malnourishment, which all have higher prevalence than the actual 3 to 5% commonly attributed to ADHD. So before jumping to a conclusion with the parents that the kid has ADHD, because the implication is he needs medication, the one that says he doesn't have it, no, he doesn't need medication. But we'll talk about that in a minute. First, to do it properly, you got to rule out medical problems. Vision, can the kid see? Is that why he's not paying attention in the classroom? Can he hear the teacher? Is there a thyroid condition which will cause hyperactivity or hypoactivity? Does the child have hypoglycemia or diabetes, which will also cause erratic behaviors and poor attention because your blood sugar is impaired? Does the child have allergies, or they're sniffing and their ears are clogged up because their nose is stuffed and they can't hear, even if they don't have a hearing problem? So if they've got allergies, they're also irritable. Their eyes are itching, their nose is stuffed, and they can't pay attention when the teacher's talking, so they miss. And then the teacher says, you've got to get evaluated for ADHD because you're not learning. Neurological disorders, all sorts of things can happen. There was one report in the psychiatric literature that showed this kid going on a neurologist's table, sitting on the table, and the kid was squirming around. The mother had him on Ritalin for 2 years, brought him in, wanted a further assessment, and the doctor diagnosed it as he had too tight underwear. And that's why he was wiggling along, trying to pull the underwear away from it was too tight. So he was wiggling all day long because the mom had not changed the size of his underwear in years. So you can get things like that happening. Rule out primary emotional and psychological problems, anxiety, depression, conduct, oppositional disorders. All of these will create the symptoms of ADHD, independently and in combination. Psychosis, thought disorders will also get kids not paying attention. and acting weirdly. Conduct a thorough family history and current family assessment. Is the kid going through divorce? Is there a lot of conflict in the family? The effects of divorce, we all know, that'll cause kids, by all the research we know, for the first 2 years, 100% of kids will show symptomatic behaviors. So when I get parents saying, my kids, we're going through a divorce and I want you to see my kid and treat him. I said, for what? Well, he's been really depressed lately, or he's showing a lot of anxiety, or he's pushing back on everything, non-compliant. I said, well, what would you like me to treat? You're going through a divorce. That's normal. So for 2 years, 1 to 2 years after a split up, and divorce is defined by children is when mom and dad don't live in the same house. We call that a separation. They don't know from legal divorce, just that's what they call it. So when the kids start showing symptoms after a breakup, I don't treat it. I think that's a ridiculous thing because you don't even know what you're treating. I tell the parents, you know, you can get somebody who will hold your kid's hand, but if they go back to you fighting with each other, it doesn't matter. You just wasted your money and you wasted an hour of the kid's time. So I'd suggest you get a good parenting plan in effect that covers all the problems that the child has. If the child has any problems after that, come back to me. I'll be glad to treat him as a therapist. So pay attention to the effects of divorce and separation on children, and don't go concluding with the parents the child has ADHD or any of these other conditions. Rule out primary learning disabilities. That will also get kids to have problems. For your information, only 40% of ADHD kids have learning problems. ADHD does not translate to learning disabilities. And only about 40% of kids with ADHD diagnosis are on medications. ADHD does not require medications. In some cases, it's helpful, but it's not a slam dunk that the two are linked. Use the DSM criteria for ADHD if you're getting technical with the parents to satisfy one or both of their requirements. Get many ratings from many different people in different settings. There's no medical test of ADHD. It's all by observation. There are various rating scales that you give to the teacher, to each parent, and even to the child if they're old enough. And you triangulate the data and come up with conclusions. Problem is with these rating scales, almost invariably the teacher, if they're having trouble with the kid's behavior, rate the kid very high in ADHD. If they're not showing that behavior at home and the parents are very tolerant, the parents will rate them very low or non-existent on ADHD. And the kid rates them typically low too because they don't want to be labeled. And so what do you do with that? You're supposed to get a combination of those. So it's a very imprecise tool to have these rating scales. And even pediatricians give rating scales to the teacher and diagnose the kid based on that without an awareness that expectations of whether you want the kid to calm down or not determine how you rate these scales. Psychological and behavioral disorders continue to anxiety disorders. The most common types are separation anxiety. By the way, my recent review of the literature on anxiety with children shows that they've come back to what Freud said originally. All anxiety in children is basically a separation anxiety. Although the most common type in DSM is DSM 10%, which presents concerns about attachment. But the literature is suggesting that it all starts with separation anxiety and then it morphs into other stuff, like specific phobias of dogs, social situations, obsessive compulsive disorders, which in the DSM-5 was carved out as a separate disorder in and of itself, out of the anxiety category, which is problematic because I don't see it that way. With rare situations, there's genetic contributors to obsessive compulsive disorders. Anxiety with younger children is commonly expressed as somatic symptoms. So you'll see kids who complain about tummy aches and headaches, but it might be anxiety and not real. But you want to rule out physical causes. Conduct disorders. Okay, I realize I've been babbling too much here. I'm going to zip through some stuff here. So conduct disorders, 2 to 6%. Oh, I'm sorry. Characterized by acting out, externalizing rule-defying behavior, can be oppositional, aggressive, delinquent, and or antisocial. Conduct disorders are problems for co-parents in that the kid is acting up and each parent is pointing fingers at the other parent as the cause of it. But some of these can have problems that are related to temperament. It can be related to creating a bad fit as a result of temperament. And it can also be independent problems within the kid related to school, related to peers, related to just the family breakup, etc. But when the parents start pointing fingers at each other as the cause of it, or I can't get the kid to go out the door to go to your house so he can't visit you, that's a problem. Sometimes that's an anxiety expression, sometimes it's a conflict disorder. But you've got to get these things therapeutically treated so that the parents stop arguing over it and understand what's really going on. Okay, I'm going to skip through the individualized parenting plan. I do have the article available, Heidi Perriman's contribution to our article on family court cases with special needs kids. So I'm going to zip through these since you can read those. And I want to get to general strategies for addressing special needs children. So these are things that I came up with that I found works for me as general strategies. So in interviewing parents in a mediation or a co-parenting situation, always ask about the child's health or developmental issues in the initial phone call. I always interview parents on the phone briefly, sometimes 5, 10, 15 minutes, 20 minutes, a freebie, because I get so much information about what I'm walking into for first session, whether it's mediation or even therapy. But in mediation in particular, hearing from each parent about these things separately in phone calls gives you a whole lot of information of what they already agreed to and what I have to give some preemptory educational dialogues about or monologues to get the parents on board with what these conditions are. Ask about their health. Does the child have any chronic health issues? Is the child sick? Has he been sick recently? Any developmental issues? Because they won't mention it. And if I ask, oh yeah, I forgot to mention he has autism. Oh yeah, he's got diabetes. Oh yeah, he's got chronic peanut allergy. Secondly, encourage both parents to talk with the doctors together. This is the operative word right here, together, if possible. I will strongly encourage them and tell them horror stories of going separately to the doctor. Doctors don't like conflict. Doctors don't like co-parents, except if they're cooperative. Doctors don't like two parents who won't talk with each other. So they'll tell you whatever you need to hear to get out of his office so he can see his next patient, because he or she has, 20 patients in the waiting room. They can't sit and talk about your family problems. So if you both go together, you're going to hear the same thing with no spin. Take notes, record it if you need to, and then you have at least a common platform of what the problem is that you're going to deal with. I say, if possible, I'd say mandatory. Just get it going together. And if you don't, I'll tell stories of each parent went to a different doctor. Each doctor prescribed a different medication for the kid's flu, heavy duty stuff, and the child died because the interaction of those two meds were incompatible, synergized, and caused the child's death. Horror stories like that are really, really motivating for parents. Arrange for the child's health professional to attend a mediation session if necessary. If the parents won't agree, I said, okay, next session you bring the pediatrician here, or you bring the therapist, or you bring the neurologist, and then we'll continue on. Fourth, highlight the extreme dangers in lack of cooperation. That story I just told you about the child dying from two different doctors giving two different meds and not conferring with each other because the parent never said the kid was going to another doctor. If one parent clearly knows and attends to the child's needs best, designate by either persuasion or court order. Here's where facilitated mediation is worthless. You need to get evaluative. You need to be able to tell them what to do because they won't do it intuitively. That parent to be the primary caregiver. I'll move the mediation to one parent's going to be primary caregiver. And if it's a litigation case, I'll encourage one parent to go for primary caregiving until the other parent gets on board with knowing the child's special needs. Encourage the other parent to start learning about the special needs and routines. Be sure the parent specifically negotiate short-term care. Before you walk out of the office, you need to agree on what you're going to do today with the albuterol. You go to the store right now, get 2 canisters instead of 1. If you need Benadryl to take care of the allergy response, go get that. Don't let them walk out unless you're now responsible for this kid on some moral level because you know their need and you start to turn over that responsibility to the parent. As the professional, you should yourself go online. Online is everything known to human functioning. Advocate for well-researched treatment approaches, not hokey, new agey kind of stuff, because there's good research on good treatments for all of these. Encourage parents to use the same healthcare provider. Just yesterday, I had a dad who said, I'm taking this kid to my own doctors. And the mother said, you can't do that. Look what Saposnek told us. I don't give a damn. I'm not sharing any doctor with you. You're horrible. It's just really frustrating when they do that. Have the parent designate a third professional as a tiebreaker in the event two doctors disagree. If a parent disagrees with models like traditional versus alternative care, which we get a lot in Santa Cruz, encourage each parent to research the other's model and bring in data and then negotiate. That's a really good technique. Use continuity of care as the guiding principle for special needs kids. In move-aways, before I would encourage a move-away, I want to make sure they have the entire regime of 6 or 7 or 8 professionals needed to help an autistic child. You have the allergist set up for the allergy child. If you have therapists set up to deal with the psychological problems or developmental problems. But continuity of care is critical. You can't just move because you want to get away from the other spouse when you have a special needs child. Be very careful. Balance the child's needs for continuity. So I've had cases where a parent has set up a whole set of professionals at Stanford. They've been doing it 3 or 4 years with this kid, and they've got it down. They've got it wired, and now the other parent wants to take the child and move out of the county. No, you don't get to do that. You go recreate wherever you're going what this child needs, and then come back to court and talk about it, or come back to mediation. Encourage informed negotiation for long-term planning with a lot of data. They each bring in research to prove their point. Encourage fewer schedule change. With most of these disorders, the fewer schedule change, especially the ones where adaptability is a problem, because changes are really hard for kids who are fixed into patterns. Reconsider the mandatory requirement of custody goes to the more cooperative parent. It's that cooperative parent clause that's in a lot of jurisdictions. And that parent who's most giving to the other parent may not be best for this child, because may not really know the regime of this special needs child. So you got to be cautious of that. Just because they're more cooperative doesn't mean they're not the best for the child. Take seriously the concerns of a parent who looks hysterical advocating for a special needs child. I encourage him, go into court and look hysterical. I mean, come with data, don't just be emotional. But these parents, especially moms, actually know their child. They're attuned to these special needs, whereas the dad may not have ever paid attention to it and doesn't know much about it, and is, by all the things I've talked about, putting the child at risk. And lastly, I suggest, this is the last comment. My last comment is replace best interest of the child with the enhanced standard of best interest of the child's special needs. And I think if we use this as a guiding principle, we'll take care of this topic. Thank you very much for attending. This is where we put the clap sign.
Thank you, Don. Yeah.
Wow, right on the button. How about that? I've never done that before.
Yeah, and just I know that I wanted to make sure that people know there is a they can get that attendance certificate code, which is 7 uppercase P as in Paul, uppercase E as in Edward, number 7, lowercase T as in Thomas, uppercase R as in Robert. Again, that is 7 uppercase P Paul, uppercase E Edward, number 7, lowercase T Thomas, uppercase R Robert. Wow, Don, that was a tremendous webinar that you just gave, giving so much information. And I received more than one comment from people about how outstanding it was.
Good, thank you.
So thank you very much for presenting it. I know we're a couple of minutes over here, so I just want to mention to people that there are a couple of additional webinars coming up. April 12, Mediating Relocation Move-Away Cases with Woody Mostyn and Lynn Waldman. And then May 23rd, Don is going to be back with another webinar. Don, what's that one going to be about?
The underbelly of high conflict cases. Going to look at all the things that drive you guys nuts.
Awesome. So really just a ton of information coming down the pipe from APFM. We'll hope you'll be there. Again, Don, thank you very much. Thanks to Bob Horowitz and Josh Krause for organizing these webinars, and everyone else for being there today. And please look in your email boxes for a survey. We do ask people just to give us a couple of minutes of feedback. Let us know how we did today so that we can do even better next time. Don, again, thank you very much. Terrific job.
Thank you all for coming.